All right, let's jump straight into a high-yield mixed block simulation. We're targeting complex crossover pathologies today. As clinical consultants mastering these intersections, it's completely non-negotiable for top-tier diagnostic accuracy. We're kicking things off with the granulomatous drivus sarcoidosis, a disease that absolutely mandates a precise understanding of both pulmonary architecture and endocrine feedback loops. Let's get to it.
Ground your clinical differential the absolute second you see this presentation. You're looking at a classic initial radiograph showing bilateral hilar lymphadenopathy, and you'll often see it paired with reticular opacities. When this specific imaging profile shows up in a young to middle-aged patient, especially an African-American female, it has to immediately trigger your sarcoidosis diagnostic matrix.
So, what's the exact pathogenesis here? Well, an unknown antigen acts as the primary trigger. This then drives a massively exaggerated CD4-positive T-cell response. The end result of all this localized immune hyperreactivity? The formation of non-caseating granulomas. You've got to remember, this exact cellular cascade is the fundamental engine driving literally all the systemic manifestations of this disease.
Now pay close attention to the strict diagnostic rule here. Never rely solely on elevated serum ACE levels. They just don't have the sensitivity or specificity, so they're strictly supportive. Definitive confirmation absolutely demands a tissue biopsy, like a transbronchial biopsy that actually demonstrates those non-caseating granulomas. And crucially, you have to aggressively rule out infectious mimics like TB and histoplasmosis with negative microbial staining.
Let's analyze the endocrine mimic. How exactly does a pulmonary disease cause hypercalcemia? The high-yield mechanism is this. Granulomatous macrophages autonomously express the enzyme 1-alpha-hydroxylase. This causes the completely unregulated conversion of 25-hydroxyvitamin D directly into the active 1,25-dihydroxyvitamin D. And that process drives intestinal calcium absorption and hypercalcemia, totally independent of any parathyroid hormone regulation.
You really need to isolate the clinical variance between hypercalcemia sources. Primary hyperparathyroidism gives you high serum calcium driven by inappropriately high PTH levels. But in stark contrast, granuloma-mediated hypercalcemia in sarcoidosis gives you high calcium with strictly suppressed, often undetectable PTH, right alongside that elevated active 1,25-dihydroxyvitamin D we just talked about.
Make sure to integrate this dermatologic marker into your diagnostic matrix. This is erythema nodosum, these tender inflammatory nodules typically showing up on the anterior shins. When you combine erythema nodosum with bilateral hilar adenopathy and polyarthritis, you're looking at Lofgren syndrome. It's a highly recognizable, specific acute presentation of sarcoidosis.
All right, we arrive at our first integrated assessment. Evaluate this clinical vignette. You've got an African-American female with a persistent dry cough, erythema nodosum, a serum calcium of 11.5 milligrams per deciliter, and an undetectable PTH level. Your job is to isolate the precise metabolic driver of this patient's hypercalcemia.
Let's evaluate these 5 highly competitive mechanisms. Which specific enzymatic or cellular defect is actually responsible for this clinical presentation? Every single option here represents a distinct pathway for hypercalcemia, but only one aligns perfectly with the multisystem presentation of sarcoidosis.
And the answer is autonomous 1-alpha-hydroxylase expression by macrophages. This is the only correct mechanism. It definitively distinguishes it from paraneoplastic syndromes driven by PTHrP, which you'd see in squamous cell lung cancers, or local osteolytic hypercalcemia driven by osteoclast activating factors in multiple myeloma. It's definitely not driven by excessive 24-hydroxylase activity. That actually degrades active vitamin D. And finally, a defective calcium sensing receptor, that points to familial hypocalciuric hypercalcemia, which absolutely does not fit this systemic inflammatory profile.
Module 2, Hypersensitivity pneumonitis and antigen exposure. We're shifting our focus now to an immunological matrix strictly driven by inhaled environmental antigens, which is a sharp contrast to the unknown systemic triggers we just covered.
Let's contrast the isolated immune response of sarcoidosis against hypersensitivity pneumonitis, or HP. HP is an exaggerated immune response defined by a mixed type 3 immune complex and type 4 delayed hypersensitivity. It is strictly driven by inhaled environmental vectors. Think thermophilic actinomyces in farmer's lung or avian proteins in bird fancier's lung.
You need to recognize the temporal divergence mapped out here.
Heavy, acute antigen exposure triggers symptoms within just hours, fever, chills, and dyspnea that closely mimic an acute viral pneumonia. On the flip side, low-level, continuous exposure insidiously causes chronic HP. That presents over months to years with weight loss, progressive pulmonary fibrosis, and ultimately devastating honeycomb changes in the lung parenchyma. So, the absolutely crucial point regarding management is this first-line mandate. Complete avoidance of the offending antigen is the primary and most effective intervention, full stop. Systemic corticosteroids are strictly reserved for severe, acute episodes or progressive chronic disease that's actively failing despite strict environmental antigen avoidance.
Let's differentiate the fibrotic presentations. Idiopathic pulmonary fibrosis, or IPF, lacks a clear trigger, mostly affects older males, and has a really dismal prognosis. Chronic HP, however, has an identifiable environmental exposure and reveals prominent lymphocytes, specifically greater than 20% on bronchoalveolar lavage. That is a massive key distinguishing factor from IPF. Take a look at these diffuse fibrotic changes. This demonstrates diffuse parenchymal opacities typical of advanced interstitial lung disease. Because these changes can easily mimic idiopathic processes, taking a meticulous occupational and environmental exposure history is absolutely paramount. It's the only way you isolate the correct diagnosis and prevent irreversible fibrotic destruction. Let's execute this next integrated assessment. A bird breeder presents with progressive dyspnea, weight loss, and upper lobe predominant fibrosis. You need to prioritize the intervention sequence for this specific environmental exposure. Select the absolute first-line management step from these 5 distinct clinical options. You have to balance the progressive nature of the fibrotic disease against the root immunological trigger. Complete antigen avoidance is the only correct first-line therapy here. Initiating preemptive immunosuppression with systemic corticosteroids without first establishing strict environmental control, that is a critical management failure. Pirfenidone is an antifibrotic reserved for IPF. Empiric antibiotics have literally no role in this sterile hypersensitivity reaction, and lung transplantation is an absolute last resort for end-stage fibrosis, not a primary therapy.
Transitioning to our final module, silicosis and macrophage paralysis. We're focusing on the pneumoconioses, specifically the structural and functional immune disruption caused by silicosis. This absolutely requires an intimate understanding of occupational inhalation pathology.
Let's map out this destructive sequence. It starts with the inhalation of crystalline silica dioxide, which is super common in sandblasting, mining, or stone cutting. Alveolar macrophages ingest these particles, but the silica physically disrupts the cells, forcing macrophage apoptosis and a massive release of fibrogenic cytokines. This sequence is what builds those dense fibrotic nodules heavily concentrated in the upper lung zones, classically presenting with eggshell calcifications of the hilar lymph nodes.
Lock in this mechanism right now because it is an exceptionally high-yield clinical trap. The ingested silica physically disrupts the macrophage phagolysosome. This highly specific intracellular paralysis totally destroys the cellular immune system's primary defense mechanism against mycobacteria. Because of this, these patients are rendered profoundly susceptible to severe Mycobacterium tuberculosis infections.
Let's assess this final clinical vignette. A retired sandblaster presents with progressive dyspnea, upper lobe nodules, and hilar eggshell calcifications. Apply the infectious vulnerability trap we just discussed directly to your diagnostic sequencing.
Evaluate these 5 options and identify the strict mandatory protocol for any newly diagnosed silicosis patient. Think carefully about what poses the most immediate, preventable threat to this patient's life based on their specific cellular defect.
You must select immediate latent TB screening. Failing to screen for and rule out latent tuberculosis using an IGRA or tuberculin skin test in a patient with silicosis-induced macrophage paralysis is a fatal clinical error. Yes, routine spirometry and high-resolution CT are necessary for mapping the fibrotic extent, but they are entirely secondary to mitigating the catastrophic risk of reactivated TB. Antibiotics and bronchoalveolar lavage are inappropriate as primary mandated steps here. Ensure these mechanisms are locked tightly into your clinical framework.